Good morning, everybody. I'm Dr. Mohammed Mahmoud. Today we are speaking about obturation, and first topic is the timing of obturation. When to do obturation? To do obturation, it depends on the patient's signs and symptoms, pulp and periapical status, and the degree of difficulty. Regarding the patient's signs and symptoms, if the patient is coming with a vital pulp, if it's a vital pulp with acute pulpitis without apical periodontitis, you can go for single visit endodontics. You can do access cleaning and shaving and obturation in a single visit. If the patient have a acute pulpitis but with apical periodontitis, then you can go do only emergency treatment and you make delayed obturation after apical periodontitis resolved. If the patient is coming with non-vital pulp, if you have no signs and symptoms, you can do it in a single treatment visit, but it's preferred to do cleaning and shaving, make intracanal medication calcium hydroxide for 7 days, then obturation has to be performed. If the patient is coming with signs and symptoms like sinus tract, swelling, or whatever, then you have to do an access, cleaning and shaving. You can do irrigation with chloroxidine to increase antibacterial effect, and then you go for calcium hydroxide intracanal medication until the signs and symptoms resolve, then you can go for obturation. Regarding difficulty of the case, it depends on if they have a difficult case with different angles or curvatures or long roots or very fine canals, then it's preferred that you can go cleaning and shaving in the first visit, and second visit you go for obturation. So as not to be tired and to do it perfectly in a different way. And to be obturation done, canal have the following criteria. The canal have to be clean and dry. We have proper radicular preparation, no pus or exudate, no bleeding, no swelling, and no sinus tract. So to do obturation, we need obturation materials. And for obturation materials, have an ideal requirement to be easily manipulated and to be dimensionally stable with no shrinkage, seal the canal laterally and apically, and no irritation to periapical tissues, and also impervious to moisture and non-porous. Unaffected with tissue fluids, no corrosion, no oxidation, inhibit bacterial growth. It has to be radioapic to be visible in the X-ray, don't discolor the tooth structure, and to be sterile and easily removed from the canal if we need to make retreatment. These three materials we were using silver point, and the history is not used anymore. And then gutta-percha, which is most widely used now, and Rizilone is a mesacrylate based points. It seems like gutta-percha, but it's mesacrylate based. Regarding to the composition of gutta-percha is mainly 19 to 22% of the gutta-percha is gutta-percha, and the major part from 59% to 79% is zinc oxide as a filler. It also have heavy metal salt as radiopacifiers to be radiopaque in the X-ray, and then wax and resin as a plasticizers from 1 to 4%. The gutta-percha is available in the market in two forms: standardized form like 15, 20, 25, 30, 35, like the normal files, and conventional. And the conventional is not standardized. You don't have a different size for the tip. It has to be measured as fine, 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 medium. It's a size for the tip and size for the body. Also, the gutta-percha available from size 10 to size 140. This is the availability, and it can be completely color coded to be completely colored, or the color to be only on the tip of the gutta-percha. Also, it is having to be in a taper 2 as a conventional gutta-percha, or it can be greater taper, taper 4, or taper 6. And the same, it can be only colored on the tip, or it can be completely colored for the whole body of the gutta-percha. Also, there's the gutta-percha for thermoplastide injectable techniques. It's gutta-percha pellets, so you can put in the gun to be heated and then be injected. But it needs heat, so it's thermoplasticized injectable. And at the same time, you have a cold injectable gutta-percha, which is GuttaFlow. It doesn't need heat. It's a capsule. You put in an amalgamator, and then you inject it to the canal. And now it's coming in another form. It comes in a Automix syringe, two syringe with Automix, and then being mixed and inserted directly inside the canal without the use of amalgamation or whatever. And there's a medicated gutta-percha with containing calcium hydroxide, and gutta-percha containing chloroxidine, and these are used as intracanal medication points, the same like calcium hydroxide. Also, we have obturators, thermofill or thermal or carriers, carrier-based obturators, and we have resin-based coated getaperca like Endo, and we have also getaperca impregnated with glass ionomer like active GB, and there's a difference between active GB and active GB. Active GB is chloroxidine points, and active GB is a getaperca impregnated with glass ionomer for monoblock obturation system, which will be discussed later on in this lecture. Also, we have a Rizilon. Rizilon is a methacrylate based points, the same shape like getaperca. It's also have a coding, color coding. This is a pellets for thermoplasticized injectable. It can be taper 2, taper 4, taper 6. Can have a different form and is used for obturation. And the main goal when this product is launched is to have bonding inside the canal because it's resin and we can use the sealer as a resin, and then we can have a bonding between the getaperca and the sealer and the canal wall to have a monoblock obturation system. So to make obturation, we need sealers and getaperca. Getaperca we discussed, and the sealers. The sealer, we need to make obturation. We need to achieve three-dimensional obturation. We have to have a three-dimensional obturation, hermetic seal to be available, and then this hermetic seal that we have to clean not only the canal, but also to see the apical part, not to have this remaining necrotic tissue as the apical part and remaining tissue. So we need to have a sealer. The sealer must have an antimicrobial effect, so it's fight against bacteria, and also has to fill all the discrepancies and fins inside the canal, and to have a binding agent that seals act as a binding agent between filling material and dentine walls. So now we have a getaperca inside, and between each getaperca point we have the sealer to fill in all the spaces that's between the getaperca parts and the points to have a hermetic seal. Also sealer as a lubricant, so as a lubricant for the getaperca to reach to the working lens and to fill each other, and to be radio opaque so as to appear in the X-ray, so we can follow where the sealer has fill lateral canals, fins, and everything to be adequate. And for the sealer, we also need to have some requirements, like it has to exhibit thickness when mixed to provide good adhesion between it and the canal wall. Had to have to establish a hermetic seal, radio opaque, very fine powder, so as to be mixed with liquid, has no shrinkage, no staining the tooth structure, bacteriostatic, exhibit a slow set insoluble in tissues. Also tissue tolerant, which means that it's not irritating the periapical tissue and soluble in common solvent if we need to make retreatment. For the types of sealers available, zinc oxide eugenol-based sealer, non-eugenol-based sealer, polymer or resin-based sealers, calcium oxide-based sealers, glass ionomer-based, silicone-based, medicated sealers, and calcium silicate-based sealers. For zinc oxide and eugenol, it has an antimicrobial effect using zinc oxide content. It's coming in a form of powder and liquid, and the free eugenol may have an irritation, which means you have to make it in a proper mix to have a, otherwise you will have a free eugenol which must be irritant. And then if we don't make it properly, it will be decomposed by water through continuous loss of water and will be weak and soluble. For the polymer resin-based sealers, the backbone is H plus, which is epoxy resin, and also we have the Epiphany, and the Epiphany is a sealer for Rizilon, and this sealer was the first attempt to have bonding between the sealer and the canal wall. Then we have an Endo sealer from Ultradent, and the same, it's also a resin-based sealer. It comes in two mixed tubes, and you inject it inside the canal, and can be activated with light to start setting, and we can have an accelerator to make it immediately set within a few minutes. Calcium oxide based sealers, it was launched because of its therapeutic effect. The calcium oxide as an bactericidal effect, but it found that it must be dissolved to release calcium to gain therapeutic effect, and this is why it's not widely used anymore now, because we don't have to dissolve our sealer to get its therapeutic effect. Glass ionomer sealer, we have Kitak Endo. It's a normal glass ionomer sealer, and you know glass ionomer have a chemical bond with dentin. And we have active sealer. Active sealer is a sealer or glass ionomer is designed to be used with the getaperca impregnated with glass ionomer to have a monoblock obturation system. Then we have a silicon-based sealers like EcoSeal, and this is also depends on that these sealers have some sort of expansion, not contraction, so it will be better to seal inside the canal. And we have the medicated sealer like endomethasone and pulse and it's contained paraformaldehyde, and this is toxic material which is now it's contraindicated to be used in any medicated sealers with aldehyde. So now if we have a look at these different types of sealers, we found that the sealer zinc oxide ethanol-based sealer has this some sort of shrinkage, calcium oxide have shrinkage, glass NO have a shrinkage but less, and then we come to silicon-based sealer have initial expansion and a slight contraction, and for epoxy resin like H+, it has initial also expansion, then have a minimal contraction, and this is why the sealers have to be used. And if you go to this picture, we found that this is a Gata-Percha sealer dentine wall. If there is a contraction of the sealer, we can have this gap formed between the dentine wall and sealer, and then there will be micro leakage, and then we can have failure and need for retreat. For the monoblock concept, which a monoblock concept is created to have a solid bonded continuous material from one dentine wall of the canal to the other, which means that we need to have a bonding between dentine, sealer, Gata-Percha, then sealer, and dentin in the other side. So for classification of monoblock concept, we have a primary monoblock, secondary monoblock, and tertiary monoblock. It depends on the number of interface found in each one. For primary monoblock, we have only the sealer inside and then the dentine wall, like MTA. If we fill the canal with MTA or bioceramics, it will be completely, it's one material, have a bonding with dentine, and we have only one interface. This is a primary monoblock. If we have a Gata-Percha coated with resin and then the sealer, then we have a dentine wall, we have an interface between the sealer and the canal wall, and we have a sealer and the Gata-Percha coated by resin. And then we have two interface between the Gata-Percha and the sealer, and between the sealer and the dentine wall. Then the tertiary, if we have these Gata-Percha have a special coating, then we have an interface between the Gata-Percha and the coating on the Gata-Percha, and then we have interface between the coating on the Gata-Percha and the sealer, and then we have interface between the sealer and the dentin. So we have three interface, and this is called tertiary monoblock obturation system. So here it's like MTA. Here it's like Gata-Percha impregnated with glass ionomer, or because it has a chemical bond with the sealer. Here, if we have like Endo, we have Gata-Percha coated by resin, and then it's come a resin sealer, then coming the dentine. So we have three interface, and this is how primary, secondary, and tertiary is found. Then the bioceramic sealer. Bioceramic sealer is available is being used to have a chemical bond with the tooth, and it's hydrophilic, which means that if you are not able to make complete dryness of the canal, it can work, and it has ideal working time. It is used friendly, zero shrinkage, and the pH value is above 12, which means it's bactericidal, so it can be used inside the canal very easy. And besides this, the flow properties of the bioceramic sealer has a very good flow properties, and it's also a monoblock obturation system. So you just inject a small amount of the sealer inside the canal, and then you get your master cone and you put it inside, and then the sealer will flow everywhere inside the canal to take the fins, the apical ramifications, and then you have a hermetic seal. And this is how it moves. You go slowly with the Gata-Percha, and the sealer is going to flow everywhere, and then you can have a three-dimensional obturation. After the sealer and Gata-Percha, we know how to do obturation, methods for obturation. To do obturation, we have a lateral compaction technique, warm vertical compaction, continuous wave, warm lateral compaction technique, thermoplasticized compaction technique. We have a carrier-based Gata-Percha like thermofill. We have thermomechanical solvent techniques and other techniques. So if we go to lateral compaction technique, lateral compaction technique is a normal technique you use normally in your sections and your daily work. Usually after you can make a cleaning and shaping, you check your master Gata-Percha points, you put it inside the canal, you take an x-ray, it fits, you have a tug back, hook to the lens, then you take it out, you choose your spreader, and your spreader, if you have a master cone like 40, the first spreader to choose is 40, but it has to reach 1 millimeter shorter than the working length. If it doesn't reach to 1 millimeter short of the working length, you choose the one is smaller, which is 35, and then you can go with 35 short than the working length with 1 millimeter. When you use a spreader, you put first the sealer on the master cone gutta percha, and you put it inside the canal, and then you get a spreader, make it shorter 1 millimeter, go to the shorter working 1 millimeter than the working length. You go vertically without any movement. You just push down from one side, and then the gutta percha will be laterally condensed to the wall. And then when you want to take it out, just counterclockwise rotation until it becomes loose in your hand. Then you go again and then counterclockwise. You go in and out until you have a passive entrance of the spreader inside the canal. If this spreader was size 35, then normally you have to use accessory gutta percha 35. But the gutta percha sometimes have a slight rebound, it's a slight release. So sometimes this 35 will not reach to the depths you reach with the spreader. Just prefer to use one size smaller. So if you use spreader 35, you are going to use gutta percha 30. And then you put it inside the canal until it works short 1 millimeter than working length after the master. And then you go again with the same spreader, and you go step by step until you fill the canal. You go with the spreader, then you get it out and you put another cone. If you found suddenly a jump happen in the gutta percha, then this means that this spreader is no more, you can use it. Take this spreader 35 away and get the spreader 30 and go more deeper. And when you use spreader 30, you are going to use accessory gutta percha 25, and you follow step by step. If you find another jump, you take the spreader out, decrease the spreader, and then until you fill the canal to be filled completely until the orifice of the canal. So you put it inside and you go with the spreader, then you put it in, and you can see that we are going up 1 millimeter with 1 millimeter. If we find a sudden jump of the gutta percha, you have to change the spreader to go with another size to fill it. For the warm vertical compaction, we don't use spreaders, we use pluggers. So we have here pluggers, and we have here heat carrier instrument, which is initiate heat to make the gutta percha soft. And these are also pluggers. So what happened is we also test the master cone inside the canal, and then we go with the heat carrier instrument. We cut it short 4 or 5 millimeter outside, and we leave the apical part, which is be soft because of the heat application inside the canal. Then we get a plugger of a proper size, and we go inside the canal and we pack the gutta percha apically. Then we put another segment of gutta percha inside, and then we pack it again. So we have to put another segment of gutta percha inside, and then with the plugger you have to pack it until to reach it. Then you put another segments, and then you pack it until you fill completely the canal. So you start testing, put the master cone, cut it short 4 or 5 millimeter from the working length. With a heat carrier instrument, it becomes soft. You pack it with a plugger, put another segment, you pack until you fill the canal to the full working length. Then for the continuous wave compaction technique, you go also test your master cone with fit inside, and then there's a device known as Obtura or system as system B, not Obtura. I'm sorry, it's system B, and it has same like pluggers, same like this part, and you choose the proper one, and the proper one is the one that reach shorter than the working length 3, 4, 5 millimeters when the canal is empty. Then you put the gutta percha inside, and when you put the gutta percha inside, you just push here, and when you put your hand here, it initiates heat immediately, and then you go inside the canal until the depth you need. Then you release your hand from this part, then the heating stops. Let it cool for about 10 seconds, then you initiate another heat, then you push it again here, and then you take it out. It will cut the gutta percha from here, taking the coronal two-thirds out and leaving the apical part soft, so you can go in with the plugger, and then you can condense it to make sealing as apical part. And after sealing of the apical part is coming, how can we fill the coronal two-thirds? To fill the coronal two-thirds, we have something like Obtura. Obtura is thermoplasticized injectable technique. We have the pellets, and these pellets is put inside this gun, and this gun is now is wireless, is not anymore connected to the device. And then when you initiate heat, it become here in this part, and then you can inject from the tip a softened gutta percha. So now after you use the system P or a continuous wave, you cut the apical part and become soft, and you condense it. Then you use the obtura to fill in, to inject this part inside the canal with injectable soft gutta-perca, and then you can pack it with your plugger to have completely filling of the canal 3 dimension. Then coming the carrier paste gutta-perca or thermofill. Thermofill, it's a plastic core inside, and this plastic core is inside coated with gutta-perca. And what happens is, this is a V-shaped plastic core, and this is a coating of the gutta-perca, and it comes for anterior and posteriorly, and comes different size. So first you make cleaning and shaping, and after you make cleaning and shaping, you get a verifier, and the verifier is an instrument to test the canal is ready for the thermoblast, for the heat carrier based gutta-perca. So you choose a size, whatever the size you are going to use, like verifier 20. If it goes easily to the working length, this means that you are going to use gutta-perca 20 heat carrier, and you can put it inside. So you have to test it before. Then, after you finish, the canal have to be clean, dry, and ready for gutta-perca. Then you put it in the oven, and when you start, this gutta-perca is going to go down in, and it will be for a few seconds, become ready, and will pop up. And once it's out, you have to take it and go inside the canal to fill the canal with the gutta-perca. And then the gutta-perca will go inside, and the remaining sealer will go out. What's the problem with this is sometimes you will find that the carrier is obvious from here, that you can see the carrier is here is out. So sometimes the canal is not completely with gutta-perca and the carrier inside. In some instance, the carrier will be the part is touching the canal, and this is not good for hermetic seal. So this was a drawback. And also for retreatment, it was more difficult to remove the gutta-perca and the carrier, the plastic carrier inside. And also if you want to make a preparation for the post preparation, it will also be difficult to prepare this. And now it's called not anymore thermofill, it's now is chloroperca. As it's a no, I'm sorry, it's gutta core. So gutta core now it's only gutta-perca with a gutta-perca core inside. It's not a plastic anymore. So it's known as gutta core instead of thermofill, which is to overcome the problems that happen with these plastic carriers. On the old days, we could have to do is we have after we go with the obturator, the forking lens, we have this thermal cut pair, and this thermal cut pair is rotating in high speed, no diamond. It also make friction, and this friction initiate heat to cut the plastic part of the obturator and leave it inside. So now we don't need to do the same, because it's a gutta core, so it's gutta-perca from outside and inside. Also from the carrier paste, we have a SimpliFill. SimpliFill is a special obturation device to a special rotary system known as Lightspeed. And this Lightspeed is not widely used anymore. And this is just to know that when you finish with one size, you have the gutta-perca opposing to the same side. You go inside to the working lens, counterclockwise, take the carrier out and leave the gutta-perca to seal the apical part. So now, after we make this obturation, how to evaluate? Evaluation of obturation. It depends on the symptoms, radiographic evaluation, and the symptoms. The patient have to be free from pain of his percussions. There is no swelling. There is nothing. So the patient have to be symptom free. After you do obturation, for radiographic evaluation, there is no radiolucency. They have no. The density is dense obturation. There is no voids. The tapering of the canal is fine, and the length of gutta-perca to be to the optimal length, not to be over obturated and not to be under obturated, depends on the canal anatomy and the apical foramen location.